Welcome everyone, and thank you for joining today to listen to me talk to you about coordinating care when systems fail. Lessons from heritable connective tissue disorders. So I'm Janna. I'm a pharmacist, medical writer, patient advocate, and sit on the Scientific and Medical Advisory Committee for Connective Tissue Disorders Network Australia, of which I'm also one of the founding directors. So I'm speaking to you from on the lands of the Gadigal people, and I pay my respects also to elders past, present, and emerging. So what is ctDNA and why are we here? So ctDNA is the national peak body for Australians with heritable connective tissue disorders. We're a volunteer and lived experience run charity focused on advocacy, education, system navigation, and supporting local research. Our goal is to build equitable care pathways so Australians with these conditions can achieve better health outcomes and greater public access to healthcare for these conditions. These conditions include Ehlers-Danlos syndrome, of which there's 14 subtypes, Marfan syndrome, Lewy-Dietz syndrome, and Stickler syndrome, but that's not by any means an exhaustive list. There's dozens and dozens of heritable connective tissue disorders. So achievements so far, despite being a young organisation, as Emma said, we incorporated in early 2024. We've already had a fairly strong impact and been received really well. We've hosted and attended parliamentary and industry events, developed and promoted community education, primarily targeted at a general practice audience with a clinical update in Australian Doctor, and a podcast series with Health Ed. The first of 4 has currently been released and available to listen to. We're also beginning to develop some system navigation pathways, and we've been involved in the co-design of key pages for heritable connective tissue disorders with RVA on the RARE portal. So why heritable connective tissue disorders? So these range from ultra rare to rare diseases and more common complex chronic illness, which we'll touch on next, with a prevalence of right down to 1 in a million with brittle cornea syndrome, up to Marfan syndrome with about 1 in 7,500 people impacted. Despite clear phenotypes and the availability of genomic testing to confirm these rarer heritable connective tissue disorder diagnosis, many patients still face decades-long diagnostic odysseys. In their quest for answers, they experience repeated referrals, conflicting advice, and at times they still encounter disbelief and dismissal. This results in fragmented care and disengagement from the healthcare system, care that becomes reactive, opportunities to prevent serious complications that these rarer subtypes can come with are often missed, leading to crisis-driven treatment that worsens outcome and increases costs and disability. So this is a common challenge across all rare diseases, not one unique to heritable connective tissue disorders. And that's why this is a really good group of rare diseases to discuss care coordination from the lens of. In the heritable connective tissue disorder, we do have a saying, it's if you can't connect the issues, to think connective tissues. And I think this could be extended to say if you can't connect the issues, let's be thinking of rare diseases. Obviously, that's not quite as catchy, but the intention is the same, that if people have really complex conditions that are multi-system, they've got multiple different specialists involved in their care, but no overarching diagnosis, it should be being looked for, that there possibly is an overarching diagnosis, whether it's a rare disease or a complex chronic illness, like a heritable connective tissue disorder. So this brings me to hypermobile Ehlers-Danlos syndrome and the question of, is it a rare disease or isn't it? The answer is no. It's historically been considered a rare disease with a prevalence of around 1 in 3,000 to 5,000, but more recent research has shown that it's actually probably as common as around 1 in 500. So it's likely in reality just rarely diagnosed, often overlooked and misdiagnosed. It's a patient group that mostly failed by the current care coordination attempts that are being made to help this patient group. And the difference with hypermobile EDS versus the other types of heritable connective tissue disorders, of which there are many, many, and they are rare diseases, is that there is no genomic marker. There hasn't been a genetic mutation or variant identified as causative for this type of Ehlers-Danlos syndrome. So it's a clinical diagnosis, and that again makes it difficult because without that confirmatory genetic test to confirm what might be a clinical suspicion of a heritable connective tissue disorder, there is some arbitrary sort of movement and variability in making that diagnosis confidently. And there's not one specialty that really takes care of this group of heritable connective tissue disorder patients currently. So again, these patients have very high care needs. They're very complex. They have multi-system condition, but it's very siloed, their care. It's often been thought of as a condition that only impacts joints or that manifests as stretchy skin, and often wrongly thought of as being a condition that has a basis that's psychological in nature. So this has led to what we now know from recent research is a 22-year diagnostic delay for hypermobile Ehlers-Danlos syndrome. So using HEADS today to talk about care coordination that could be optimized, HEADS shows clearly what happens when a complex multi-system, often female predominant condition falls through system cracks. And this is a pattern that's mirrored across many rare and poorly understood conditions. So not unique to heritable connective tissue disorders or hypermobile Ehlers-Danlos syndrome, but they do provide a really good example of this. All of these points, which we should be aiming to hit in managing these patients, do map really well also to the 8 national recommendations for rare disease health care. Okay. So how to overcome system limitations? Well, we know time, funding, Medicare, these are all the big issues that present in general practice and across the board in healthcare for these patients. GP appointments are often too short for the complex histories that these patients have. Long consultations, as we know, attract higher gap fees, and this only increases the inequity of access to the quality care that these patients really need. Many of these patients are not working. We know this in rare disease. They've got reduced hours. They can't work full time. They might be carers also. So have limited financial means and resources. So I think here, the big way to optimize and overcome system limitations is encouraging and informing patients of the benefit that might come from a longer appointment, and helping them to maybe think about the ways that they might be able to utilize longer appointments with their GP. For example, we last week put out on our social media just to get an idea of a very informal survey of heritable connective tissue disorder patients to see how many people had formal plans put in place by their GPs, and only 40% of our patient cohort that responded, and it was a significant response, had a chronic condition plan initiated for them. For a mental health treatment plan, that was only 25%, and for a home medicine review, only 4%. So although many of the community would qualify for all of these care plans, they are underutilised. So here, encouraging clinicians to think about patients that you might have that might be eligible for these plans that they haven't yet been initiated for. And when the opportunity presents, trying to really be proactive on that and discussing those with patients. We also know another big burden and system limitation is that a lot of these patients do require NDIS or disability support pension, Centrelink supports, but the reporting time for GPs, for example, can't be billed. So that is a fee that's passed on to patients, which is necessary, but again, it does increase the inequity of access for those most in need. So again, discussing with patients the ways in which you might be able to plan for reporting, build it into the reports when you are doing them, that this might be an ongoing requirement for this funding to be built into an NDIS plan, as once they are accepted as an NDIS participant, then there can be flexibility in core funding to be used for reporting, for plan reviews and the like. So that can be really helpful. A summary of changes here, and I'm sure that you're all aware of this. So it's been the process for a lot of the GP chronic condition management plans was simplified back in July of this year. So what was a two-step process is now just the GP CCMP, and that's sufficient to trigger the allied health Medicare rebatable sessions. Although it hasn't been optimised at all, it still is capped at 5 allied health visits. And case conferencing is no longer mandatory for that, but it's, of course, it's still encouraged. So the point here is that while these changes have been simplified, the process itself, the access for those with high needs has not increased. And we know that rare and complex patients often need far more allied input than they're getting. So again, maybe being creative in talking with the allied health support team about ways in which those 5 sessions might be able to be utilised to sort of develop a plan to apply for NDIS or other supports that might be needed. I also have put together a couple of slides here, just putting all of the updates together for everybody. And 2 of the plans I did want to touch on briefly was the home medicine review and the eating disorder plan. So the HMRs are valuable for safety prescribing and polypharmacy oversight and clarifying where symptoms might be drug-related for these complex patients, because they can have very complicated medication regimes. But it should be noted here as well that a lot of off-label and non-approved indication prescribing does occur, and this can be necessary and rationalised. So there needs to be meaningful conversation between a pharmacist well-versed in complex chronic conditions and the GP or specialist who's referred for the HMR as well. And eating disorder plans are important as there can be a high prevalence of disordered eating and chronic GI manifestations in heritable connective tissue disorders and extrapolated out to other rare diseases. So these might be applicable and provide another valuable, deeper expert input touch point where reimbursable plans might be able to be utilised. So this is just me thinking, my food for thought. Was that perhaps we need a credentialed rare disease educator system in time, like we have for credentialed diabetes educators, perhaps some group education sessions for people with rare diseases, because there can be a lot of commonality in the experience, might be something that could be strived for and useful down the track. So another point of how do we better coordinate the care when the system fails. So I've used here as an example a tool that's been recently released for hypermobile spectrum disorder and hypermobile Ehlers-Danlos syndrome. And it's called the Spider tool. You can check it out online. I'm going to really go through it quite quickly, but basically it triages the area of most important for patients. So it's done in conjunction with patients, and I think that this is really useful and important for all rare disease to ensure that we're triaging the plan that's most needed at the right time. So, if depression and anxiety are the most prominent symptom, it wouldn't make sense to initiate the allied health supports, as that could be a barrier to successful allied health interactions. So it may be that a mental health treatment plan is necessary prior to tackling the allied health input, just to ensure that you're maximising the impact of each of those plans, as they are so stringent in the sessions available. And also, of course, ensuring that all case conferencing is utilised. And this builds rapport between interdisciplinary clinicians, but also it builds trust with patients. So also, it's important here in this patient group, but also extrapolated more widely to rare diseases, to find and connect with the right experts, because GPs can't see experts in all 8,000 rare diseases. The skill lies in recognising when to connect. It can be really important to ask patients if they've already identified, if they're undiagnosed, they might have identified experts that deal with one of their comorbid conditions that might be worth following up and making a referral for. A lot of the time, patients do get a lot of valuable information from patient groups, and they identify with others' experience and see their own symptoms in that also. So it can be a useful place to start to find and connect to experts in rare disease or rare disease groupings of rare disease conditions. Another one is utilising patient advocacy groups and clinician directories to find and connect to experts. So, for example, ctDNA is happy to engage and will help clinicians to find the right specialist or pathway for patients as much as we can. We are a volunteer organisation, but we will try to do that. Online, though, something that you can get a quick response from is, say, the Ehlers-Danlos Society, who has a global listing of EDS-aware clinicians, but it can be sorted and searched down to state and country also. So there's a good listing on there of clinicians who are aware with heritable connective tissue disorders, for example. For undiagnosed rare diseases or complex patients, there's another organisation called Syndromes Without a Name, or SWAN. So there are utilising patient advocacy groups is, I think, key, and engaging with them. They want to hear from you. Also, the Rare portal and the Rare helpline can both be utilised by clinicians as well. They're not only patient resources, particularly the Rare helpline clinicians can contact as well. And another great way to find and connect to experts is connecting with academics or tertiary hospital researchers directly if you've got an idea of the symptom complex again, or a particular comorbid condition that is forming a part of the patient symptom complex. Many are generous with their advice and time, so that can be really worthwhile as well. The last point to touch on is to recognise that for many difficult to diagnose conditions, undiagnosed complex rare diseases, chronic conditions, there is still a huge gender bias, and that remains an additional challenge for patients, but also for clinicians treating them. So, for example, hypermobile Ehlers-Danlos syndrome makes up around 90% of all EDS diagnoses, and 90% of those patients are assigned female at birth or women, and the experience that they have isn't great. So we hear day in and day out from community members at ctDNA about the experience, and reoccurring themes that came up in an Australian study of 152 women with hypermobile Ehlers-Danlos syndrome in 2024 highlighted that most had negative experiences with healthcare professionals, which included not being listened to or believed, being dismissed, made to feel stupid, or that their symptoms were all in their head. So this further highlights the importance and need for medical education on heritable connective tissue disorders, but more broadly rare disease, especially those that do have a lean towards females or people assigned female at birth. We also know that most carers are female mothers, women, or assigned female at birth, and they are commonly still dismissed when relaying their concerns about a child's symptoms to healthcare professionals. And this is something that Again, we hear about mothers are often told that they're overreacting, suffering from anxiety, projecting. These are all things we've been told at ctDNA. We also have cases in the heritable connective tissue disorder community where carers are suspected of fabricated illness or induced illness. And kids have at times been removed from care. Only later is it found that their suspicious injuries were not in fact the result of a fabricated illness, but the result of low impact activities of daily living due to joint hypermobility causing injury, for example, subluxation, dislocation. So keeping it front of mind that gender bias is something we need to be not just actively not doing, but not participating in, but also calling out as well, because misinterpretation can have devastating consequences. In the case of carers' concerns must always be taken seriously and be a flag for a deeper clinical review. I've put together a really simple rare disease management flow, which includes, identifying those patients that you might already have or be thinking about now that are complex and have multiple clinicians in their care team, but no overarching diagnosis, encouraging them to book long consults, doing those full reviews, completing a full medication reconciliation review, doing those allied health referrals, triaging the organ systems most impacted or causing the most problems and impacts to daily living in terms of referrals, and reviewing them obviously at least annually, but in reality it's going to be a lot more frequently for these complex patients, at least until there is some better management in place that results in a better quality of life. So I wanted to finish very briefly with, this is a bit of a snippet from something I saw on social media this week, and a little bit just of a play on Clinical Pearl. Be following the right clinicians, because there is some amazing information shared online. This is from Dr. Zach Spirotis, who's an American gastroenterologist, who in this clip acknowledges that he has seen a lot of patients in his career with complex chronic illness, that the conditions weren't as uncommon as he thought. He just didn't know how to recognize them at the time.
Oh, Janna, we might need you to share the
Okay.
sound.
Yep. I'll share
Sorry.
the sound.
Thank you.
Okay. Sorry, share. Oh, it's just music. There's no words. So it's
Oh, okay.
yeah.
Nice.
So
Okay.
I'll just pause it here, where he says, I realized that there were hundreds of patients I saw who almost certainly had these conditions. He's referring to POTS, EDS, and mast cell activation syndrome. I just didn't know how to recognize them at the time. So yeah, that's the basis of my wrap up. I did go through that very quickly. I apologize. I was conscious of going very much over time. But just to show that hypermobile Ehlers-Danlos syndrome and heritable connective tissue disorders really give a clear picture and window into the bigger pictures of rare disease care. And that the system-wide challenges we see across the rare disease community of limited time and funding, fragmented care coordination, the ongoing impact of gender bias and lack of specialist knowledge really do require creative and curious minds to connect to the issues, for these patients. So thank you.
Hi, I'm Jason. I'm on the unceded lands of the Bunurong people, and I'd like to acknowledge them as the traditional owners on the lands and the respective owners on the lands whom we're meeting today. And I'd like to pay my respects to the elders, past, present, and futures who might be here today. So just a very quick introduction. I'm not Jeff Vader. I'm Jason Lamb. So I used to be a professional dancer. That's why I called myself the dance doctor, and then collapsed a lung, stopped dancing, ended up doing medicine. And now I work largely in this sort of like hypermobility and complex chronic illness sort of space. As noted, I'm completely over-caffeinated and I talk very fast. So if you have any questions, just pop them in the chat and we'll try and get back to that. So I work with ctDNA on the scientific Advisory Committee, and also a member of the Australian EDS and HSD Network of Excellence, which is the EDS Society's kind of group, kind of networks of people who are interested with expertise in this sort of space. I did find out in the chat that I'm talking with a whole bunch of subject matter experts here, so I do apologize if I'm telling you how to suck eggs. I'm a GP and a sports med registrar only, and I'm not a researcher or clinician scientist in any way, shape, or form. In terms of disclosures, I've done a bunch of stuff. I don't think any of that is necessarily a significant conflict. I guess you could refer to me or come see me or not. And obviously, I'm standing on the shoulders of giants, and none of these ideas are new or mine. Yeah, I'm just a lowly clinician. So yeah, case study. So this was a 42-year-old woman who comes with a bit of a history of single kidney, which is going well. She's got POTS. She's seeing one of the local experts on that. Asthma, bilateral hip dysplasia, AVN, right hip. She's had a couple of C-sections, appendectomy, does get a lot of post-operative bleeding every time she has an operation, and also had varicose veins, which needed to be treated before the age of 30. She had the 3 kids too are on the autism spectrum, and there was some thought that they might be hypermobile. She was currently on some fluorocortisone. She was on some dexamphetamine for her POTS. She has a migraine. So she was on some amitriptyline and had been on some low-dose naltrexone as well. And she presented kind of with some tachycardia and these odd symptoms around her head and neck. And she had seen a lot of people. So ENT had done a laryngoscopy, which was normal. They did a CT angiogram, which showed fibromuscular dysplasia and some plaque, which they didn't really know what to do with, said that she was probably anxious. And this is unfortunately quite a common sort of thing that I hear from my patients. She'd seen a neurologist who said it was not a stroke. Rheumatology said it was not rheumy. And a clinical pharmacologist physician says, I don't know, I'm just looking after the POTS. So as Janna said, everything tends to be quite siloed. Everyone looks after their own little particular little area. And it's an artifact of our medical system that, you know, the prestige goes to the hyper specialists. Who knows everything about one tiny little thing. And we've probably discounted the generalist in the big picture. So I was just trying to get a bit more into her history, and she had kind of experienced this pulsatile tinnitus. She experienced some pressure in her neck and pain and pressure in this head, some kind of vague neurological sort of stuff. Felt like she was going to pass out. It was quite lucky that she was actually driving at the time. She was able to pull over safely, felt her throat going into spasm and found it very hard to breathe or speak properly. She had a couple of these episodes that last about 10 seconds, and then it kind of gradually eases by itself. She had a carotid ultrasound organized by the ENT about a week later, and when the pressure was over her neck, it actually set off the spasms again. Her heart rate went up to 140, and I can't see what the BP went up to. I think it's like 180. It was pretty high. They freaked out, popped her in an ambulance, took her to hospital. She got some fentanyl along the way. But like the other episodes, it kind of gradually settles by itself. ED had a look, didn't know what to do, discharged. And then after this episode, she felt, I've kind of abbreviated this. There were a couple of these episodes which she built up to this. She felt really drained by these episodes and felt her head was a bit of a bobblehead and she needed a neck brace. Her resting heart rate was higher than usual, and her blood pressure was high. She generally felt shaky. She was having trouble swallowing, talking, was irritating her throat, felt swollen. She was actually unable to leave the house for about 10 days, and she found that she was very sensitive to smells. She works as a nurse unit manager, and she was finding that, you know, at work, certain smells would kind of trigger some of these episodes. And every time she had one of those, they would precipitate a crash, and she had I had to spend some time at home and just describe it very hard to sleep, and a pressure in her head when she was lying down. Had another one of these episodes, hypertensive, tachycardic, went to hospital again. There's some ectopic seen on ECG, thought she was anxious, gave her some razapam, and it settled. So, like I said, she'd seen all these specialists and no one really kind of knew what was going on. And so I can't actually remember how the heck she found me. I think probably on, yeah, I think she was on one of those, on the Facebook sort of groups. And so she kind of rocked up with that history. And so I thought I'd, consider hypermobile EDS or an EDS type diagnosis. And yeah, sure enough, she actually made the diagnostic criteria for a hypermobile EDS. Um, I was looking at her neck and she was sharp Pursa positive. And if you're sharp Pursa positive, you don't really need to go into a transverse ligament test. She was quite tender around the neck, along the sternocleidomastoid and around the styloid, particularly around the left side. So I did, the laser pointer on the hat trick for proprioception, and she had quite poor proprioception around that. Um, Dug a bit more into history. She's got quite a slow gut. Um, she was only having one bowel movement a week, and her NASA lean test was markedly positive, and she was really tachycardic. Um, so I went and dug up her CT angiogram, and does anyone notice what is possibly a little bit unusual? I don't know why I'm asking that because I can't see any responses. But anyway, so these little guys, little stylo processes are quite long. Um, and so that brings up the possibility of something like an Eagle syndrome, particularly with the fibromuscular dysplasia, which was noted around her vessels, which actually coil around these processes. And abdominal X-ray shows quite marked fecal loading. And so, trying to put all of this together. So, there's some degree of hypermobility there. And because she had the hip dysplasia, she had the varicose veins, which need to be done very early. She's got this fibromuscular dysplasia. There's a possibility of a vascular type process, one of the monogenetic forms. I was suspicious of an Eagle syndrome or a stylojugular sort of syndrome, probably type 2. Some degree of head instability. She was describing this bobble-headed sort of feeling. And so kind of my thought was that there was this interaction between some connective tissue laxity, this fibromuscular dysplasia. And so instability around that allows the tortuous vessels and the nerves which run around the vessels kind of irritating along that stylo process. The sensitivity to smells and volatiles is quite suspicious of something like MCAS, mast cell activation syndrome. And then this raging tachycardia and hypertension. I was actually thinking that like we know she's got POTS, but maybe dexamphetamine is not the best treatment for that because that's going to drive up, that's a big sympathetic driver. You're going to drive up the blood pressure, you can drive the heart rate. Works really well for some people, but some people finds that it's can be quite troublesome for them. And this really slow gut transit, we see this in both hypermobility as well as POTS. One of the gastroenterologists I work with describes it as a dysautonomic gut. Um, people with POTS tend to be a bit dry in terms of fluid, and so you end up with drying out the poop. The medications also slow down the gut. So yeah, they can all be part of this sort of picture. So what do you do when you've got all this sort of stuff? You get some help. So I talked to some mates because FMD, I don't know squat about that. So I talked to a cardiologist who suggested adding some rosuvastatin, some aspirin to look at that. As part of FMD, we do need to scan all the vascular beds to see if there's anything else going on. And she did have a bit of a tortuous renal artery. So Dr. Renal and Renal was dobbed in as the people to look after FMD surveillance. I was pretty convinced of this picture of a stylojugular syndrome, but it's really hard to get an ENT interested in this sort of thing. And actually, some of the ENTs I talked about, interestingly, were said that A, I haven't heard of about, B, it's not that. I'm not sure how you can say it's not that if you don't know about it, but there it is, and that they were actually probably just anxious. But eventually I was lucky enough to find some ENTs that I could have a good conversation with, and they accepted her to have a look at. We thought that she had some CCI, and so a neck specific physio, with the gut and POTS, a dietitian can be really helpful in MCAS, and exercise physiologists to kind of help manage overall load and energy management and pacing, all that sort of stuff. So having people who are really experienced with connective tissue diseases, with energy limiting diseases, with POTS is really helpful because they don't, this population tends not to respond exactly the same way as your typical sort of patient. So having specific expertise is really helpful. And that's where some of these networks of excellence are really good, because I've got, a network of people who I can be really confident about the quality of their thing. As kind of GP with special interests sort of thing, the GPMPs that I can't remember what the new name of it is, that Jan talked about, should be done by the regular GP. So part of it was communicating back to the regular GPs. Now I know that a case conference is kind of ideal. Unfortunately, it's actually remunerated like bugger all, and trying to organize a lot of people to come together is at the same time is difficult and not funded. So yes, it would be great to do that. In practice, it is quite tricky outside of a hospital setting where you can kind of physically humbug people to get together. So in lieu of that, what I try and do is, I write extremely long and detailed letters and make sure that everyone is kind of included in on that. And sometimes people read it, so that's always nice. Thought we'd try some MCAS treatment, and I talked to her treating doctor around for her POTS, and actually changed her over from the dexamphetamine to ivabradine. And because she's a bit hypertensive, we actually used the long-acting metoprolol as well. As Janna said, the medication reviews can be really handy. I'm a little iffy about it because I've had a few of my patients, their regular GP doesn't necessarily agree. They order a DMR. The DMR is like, oh my God, why is this young person on beta blockers? Come off it. Why are you on antihistamines? Come off it. So as Janna said, it's really important that if we are going to do that, that we have communication, or that, the specialist kind of letters and the rationale is there so that the pharmacist can work with that. Because a lot of this is kind of off-label and would be unusual in a young person. And because of some of those features, we referred to genetics. She was actually rejected from the Monash, the public genetic service. I did talk to a private geneticist who has accepted. And we also cleared out the bowels, because stasis in the bowels is going to be a potent sympathetic driver, be constipated, and so that can make the POTS worse. So, and it can also make MCAS worse. So that's where the dietitian can be super helpful with that. The ENT saw them, thought that they needed neurology to confirm the Eagles and the Siler-Douglas syndrome, which a professor of neurology did. I kind of feel like that he Stephen Bradbury'd it, because I think I did most of that. And everyone is now praising the neurologist for a brilliant diagnosis. I have a chip on my shoulder about that. But anyway, she is now on a wait list for surgery, and hopefully that will kind of resolve some of these sort of head and neck sort of symptoms. She also is doing really well with a neck-specific physiotherapist, getting some more strength and control around that. This was just a brief thing about vascular EDS and some of the features which might prompt a referral to a geneticist and consideration of a monogenetic sort of form of that. And yeah, this is what we ended up medication-wise. So yeah, trying to stabilize some of the mast cells, which is reducing some of her reactivity with volatiles and with smells. We modified her POTS treatment. I forgot to write this down. I actually came up with a concoction of baclofen, a topical concoction of neuropathic medications and baclofen, which helps reduce some of the spasms and the sensitivities around her neck. And so that actually reduced the number of episodes she had, which was kind of helping us hold until she can do the surgery. And so the case's name was, case for Higgins dictum, which was the idea that patients can have as many diseases as they damn well please. So, there's connective tissue which underlies it all. Unfortunately, we don't actually have anything which can treat heads or these connective tissues per se. There is no disease modifying treatment, so we are kind of like playing whack-a-mole, and that's where something like the spider can be really helpful, is like prioritizing, well, what are the most problematic symptoms, and we whack those moles as best we can. So yes, thank you so much for coming during long weekends, holidays, and that sort of thing. We can make a difference, and I hope that was not too much egg sucking for you all.